welcome. I'm Dr. Nicole Rochester, your host for today's Patient Empowerment Network program, and we are so happy that you've tuned in. Today, we're going to be talking about how prostate cancer patients can truly get the best care, no matter where you and your family live. We're going to talk about things like, how can I remove roadblocks in my care to gain access to state-of-the-art treatment? Will my insurance limit me if I want to get a second opinion? As a care partner, how do I best advocate for my loved one? And is a clinical trial right for me? The answers to some of these questions we've received revolve around awareness, feeling empowered to ask questions, and connecting to the right resources at the right time. In this program, we'll be learning just that as we meet our experts. It is my honor and privilege to be joined by Dr. Petros Grivas, Associate Professor and Clinical Director of the Genitourinary Cancer Program at the University of Washington, and Dr. Yaw Nyame, Assistant Professor in the Department of Urology at the University of Washington. Thank you so much for joining us today, gentlemen.
Thank you for having us.
Thank you so much for having us. It's an honor and pleasure to be with you.
It is my honor as well. Please remember that this program is not a substitute for seeking medical care. So please be sure to connect with your healthcare team on the best options for you. Now, let's take a few minutes to set the stage and give a brief overview of barriers in the way of achieving equitable prostate cancer treatment. Doctors Nyame and Grivas, we know that location, socioeconomic status, insurance, financial hardships, lack of urologists in rural areas, geographic distance to services, and access to transportation all play an important role in the outcomes for patients and families facing a prostate cancer diagnosis. So I want to start with our first question, and we'll start with you, Dr. Grivas. What are some of the barriers both prostate cancer patients and their care partners face when seeking care?
Thank you so much, Dr. Rochester. These are really, really important discussions, and I'm glad we're doing this program. I think you covered a number of those barriers in your introduction, and I would definitely agree with all of them because all of them are important. And the number of those factors have to do with the location of the patient, as you mentioned. Patients, regardless of race, if they live in a rural community, they may have less communication or contact with the medical care system. And that's a known reality. There is data suggesting that across different states, this access to care issue is becoming more and more noticeable. And the distance involved in some areas to get to a medical facility, let alone a specialized medical facility specialized on prostate cancer, it can be a big problem. The other issue that we have seen many times, again, in some communities more than others, is the healthcare literacy and the preventive mindset, as I call it. And that's, can transpire across races, but maybe even more intense in some of the populations. And when I talk about health literacy and preventive mindset, and it's about the relationship, right, that an individual has with the healthcare system, and sometimes the distrust, right, that may take place, and also the, I would say, comfort that the patient has to enter and access the medical care system, that they can allow the providers to take care of them. And these are real, I would say, examples that we have seen patients having this concern, of letting themselves be taken care of in a medical system. Competing problems and barriers include, financial concerns, and that's a big one, right? Insurance coverage. We know that patients with, I would say, social determinants of health may have inadequate coverage, and this may be restricting what medical facilities that they can access. And also the cost of care, copays, for example, when diagnostic tests or therapeutic interventions for orally available agents can be a big barrier. And we know compliance can be diminished when there's an amount of copay. Of course, you mentioned many other factors, transportation issues, finding, coverage at work, right? Getting day off work can be a problem for some patients. And also the cost of transportation or lodging or parking sometimes can be a problem, or even the anxiety related to go to a big city and deal with the traffic, of course. So there are many factors, of course, but I think we have to have a systematic approach how to catalog them and address them, in a comprehensive way. And I think there are some improvements, and we can talk about them today. For example, telemedicine and others. But I think the list is long, and we have to keep an open mind and engage patient advocates in cataloging those barriers. And maybe Dr. Nyame can comment further in that regard.
Thank you so much, Dr. Grivas. Yeah, you covered a lot of ground, and I appreciate that. Dr. Nyame, I'd love for you to either add to that list or maybe expand based on your perspectives.
Yeah, Dr. Grivas didn't leave me with much to cover, which is great. I think what you hear in his answer to that question is that this is really a social issue. And I think when we talk about inequities in health, we have to recognize that, race in this country and many places around the world really reflects the social construct. And so the things that really predict how people are going to be able to utilize our services and how well they're going to do reflect that greater social context. And so to me, you have to meet the patient where they are. And the strength of the relationships that you can build between the healthcare system and the communities that are at risk, especially the ones that have the highest disproportionate risk of bad outcomes or not being able to utilize services, is important. And so the barriers include all the things we talked about, right? But a lot of them that we've talked about have been very much healthcare facing, right? So we talk about transportation, but we mean that in the source of transportation to our facilities, or we talk about money, but we talk about money and the ability to pay for our services. We also miss the other ways in which those social barriers and factors impact the ability to prioritize one's health. And so that is a really big problem and something that we also need to put in the context of this conversation. I think when we take the covers off and we really see what our patients' lives are like, sometimes we recognize that it's not just about their ability to utilize the services that we provide, but that there are bigger issues at hand that also need addressing. Those aren't in Dr. Grivas and I's domain, but I think we have to understand those things to meet our patients where they are.
Absolutely. I really appreciate that both of you have really focused on those social determinants of health. I appreciate you mentioning, racism and the fact that, the patients being able to prioritize their health. I think historically in medicine, we have blamed our patients for, not taking care of themselves, so to speak, without a full appreciation of all of these barriers that both of you have just identified. So I really appreciate that. So you started slightly to talk about solutions, but let's shift to solutions. And what are some of the solutions that you all recommend for some of these barriers? And like you said, as physicians, a lot of that is going to be out of your purview, but I'd love for each of you to suggest any solutions for our patients and care partners who may be facing some of these barriers. So this time we'll start with you, Dr.
Nyame. This is an area where I think we need to do better in collecting information to understand where the need is. And so I think there's a very much a need for translational health services or patient-centered research where we do the simple thing. If I was going to open up a lemonade stand in the middle of Seattle, I'd probably ask a few people what their needs are around lemonade before I open the stand. And I think in medicine, we often offer services and solutions without having had that simple conversation of what are the needs. I think in addition to that, we have to understand that equitable care might mean offering additional services for certain populations. So for us at our cancer center, for instance, we've recently instituted a patient navigator program, something that's been around for a long time at other sites, but it's allowing us to do that, go through that exercise of providing some equitable care by helping people coordinate appointments, find their way to financial resources that might support them, and just to be there as a support in the very difficult time of having a new cancer diagnosis. So I think that's a well-proven and well-established method for helping people get good access to care. The other thing I'll add is that we make decisions, I think as humans, we make decisions through community. And sometimes that's our partner, sometimes that's the buddy at the gym, sometimes that's a coworker. And there are a lot of really fantastic patient advocacy networks that exist that can help people find this new community. And I think cancer patients share a very unique bond and a very unique way to communicate with one another because they're living through this particular diagnosis. And so in the case of prostate cancer, especially prostate cancer in Black men, you have the Prostate Health Education Network. You have Zero Cancer, you have Us Too, you have the Prostate Cancer Foundation. I'm probably leaving some advocacy groups off and I'm probably going to get in trouble. But I think that there's that opportunity to reach out to others and just learn, what did you go through? What worked for you? How can I meet my goals of care through just conversation with other patients and survivors? And I'll try to leave something for Dr. Grivas to add to the conversation, because clearly I could go on and on about this.
Dr. Grivas?
I can tell you that I'm learning every day from Dr. Nyame and his fantastic work in this important topic. And I think he covered the answer so well. If I can just add a few more things just to expand on his thoughts, and these are things that already he's doing in his programmatic development in our institution as well. I think, one of the important things we have to acknowledge, all of us, is, the issue of systemic racism and implicit bias that I think you referred to, Dr. Rochester, which I think the more we talk about it, the more transparent we are with it, the better, right? Because we can think about what are unconscious or subconscious, thoughts that we may have. Oh, this patient doesn't care about themselves. Why should we go the extra mile to help them? And the answer is we should go the extra mile to help them, because this patient, may have, less insight into the situation and they need more resources. And as a healthcare system, we should try to earn that patient, right? We should not let that patient go because every patient matters, right? And I think every life matters. I think that's important, I think overall, systemic issue to discuss. The other thing is, getting ourselves to the community. And I think there are examples of studies we have done in the Cleveland Clinic and other areas that we try, to utilize the wisdom and the help of local leaders in those communities, right? For example, underserved population, go to local churches or barbershops or gyms, as Dr. Nyame mentioned, and collaborate, work with the local leaders and see how we can have a dialogue with the patients there. How can we establish this trust that may be missing? How we can convey that health is important and prevention is important and treatment is important? How can we help with financial concerns, right? How can we get patients to the cancer center without them having to worry about how to get there? How can we reach out and have screening in the prostate cancer screening in the community if it's indicated? Then access to care through telemedicine, and that brings an issue. Do the patients have equipment for telemedicine, a computer, internet access, right? We take it for granted, but it may not be. So giving them those resources, organizing some local centers. We did this men's health day in Cleveland Clinic just to get people in a room and educate them about but also learning from them what are the barriers to take into account, not talk down to them, but learning with them and from them. The other thing is research, and we'll have to do a better job to include and offer in an equitable manner clinical trials to our patients, including patients from different races. And we are doing, I think, overall okay, but we're not doing enough. We have to do better in order to provide these opportunities to our patients. And the role of patient navigator is great. we can set examples that we have with Dr. Nyame of patients who feel much more comfortable when they have a patient navigator. Sometimes, if it happens to be on the same race with the patient feels more comfortable. They have someone that they can trust or be easier to talk to. And I think we should definitely improve our hard and work harder to provide access to research in an equitable manner to all patients. The last point I would say is patient copay assistance programs and foundations. I think we can definitely include, more resources to our patients, philanthropy, foundation support, and state programs in order to, give those patients the resources they need, again, to achieve this holy grail, which is equitable healthcare.
I love that you all are focusing on equity, which, as we know, is giving every patient what they need in order to achieve their optimal health. And as both of you have stated, that's very different than equality. And so this concept that we really have to meet our patients where they are, and that some of our patients may need a little bit more than others, and that's okay. In fact, that's really what we have to do in order to eliminate these disparities. So I really appreciate both of your thoughts. And that's a great lead in to our next segment, which is really focused on racial and ethnic disparities. And both of you have kind of, touched on this a little bit already. So, we know that there are, as with every other type of cancer and every other disease, there are significant health disparities with BIPOC patients. And so, Dr. Nyame, I'd love for you to talk about, specifically with prostate cancer, some of the disparities that you see in your practice and in your research. And then, what are some things that patients of color can do to protect themselves from these inequities?
This is a very important topic for me, and something that I am very passionate about. And as Dr. Grivas has alluded to, I'm doing a lot of research on. And I think the statistics are sobering. Black men are 80% more likely to be diagnosed with prostate cancer. So the average man in the United States has a 1 in 9 lifetime risk of being diagnosed with prostate cancer. That's probably 1 in 6 or 1 in 7 for Black men. Black men are twice as likely to die from prostate cancer compared to men of other races and ethnicity in the United States. And a lot of this is driven by the social milieu and factors that we've talked about today. What troubles me is when we talk about these statistics, I fear that in of itself is crippling for some Black men. If I have this diagnosis and I'm not going to do well, why should I do anything? And I can tell you that the literature and all the research that we do, and it gets refreshed every 10 years or so. Someone will do the study and it shows that if we have Black men and men of other races or white men, and we give them the same treatment for the same level of disease, that the outcomes are actually very similar. And a better way to state that is if you're diagnosed early and you get the treatment that you should get, irrespective of your race, it seems like outcomes can be quite good. And so a lot of what we see with regards to prostate cancer inequities are driven by lower treatment rates, and probably an impact of lower quality care. And when I say that, what does that mean? Well, do you get your care at places like the Seattle Cancer Care Alliance or the Cleveland Clinic or Johns Hopkins or MD Anderson, where you have providers who are expert and do a lot of prostate cancer care? Or are you being seen by someone in the community who I guarantee is an excellent clinician, but doesn't have the same expertise in the sense of being focused on one disease process or one set of cancers? For instance, we are genitourinary cancer specialists, a fancy term for being cancer doctors of the plumbing system, right? But because that's all we focus on, we know a lot about the process, we know what works, and we know what the standards of care are. So I think when you can get the right treatment at the right time, and you can get it from teams that are really specialized in this, that your outcomes are going to not care about what your self-defined race is when you check the box. The problem is, how do we close that gap that exists currently that doesn't allow people to get that care? And I think we've talked about rurality, right? So I think I grew up in Oklahoma, right? And I could see that if you are in the sticks in Oklahoma and you're not near a cancer center, like something down in Dallas, that your care might be impacted. But especially if you have to travel a lot and it's expensive. But we have major US cities like Los Angeles, where you may share a zip code with a millionaire, but use very different health services. So it's not always a reflection of how far you have to travel, but it also is factors about how welcoming institutions that provide high quality care can feel for populations like our BIPOC populations, who sometimes have been the subject of medical experimentation, lower quality care sometimes because they might not get shuttled to the same services historically. And I think we have a lot to undo to rebuild the trust that is required to have Black men not be fearful of seeking care from us, but be trusting.
Absolutely. And certainly the COVID pandemic has really brought that whole mistrust and distrust to light. So I appreciate you touching on that. We're going to move to talk about treatment access. And I love how this conversation is flowing because so many of these elements have already been discussed. So we're going to talk about treatment access for prostate cancer patients. And we know that sometimes the barriers that patients face, as you mentioned, actually limit their access to quality care and to appropriate treatment. So Dr. Grivas, how can we ensure that a patient's geographic location doesn't dictate the quality of care that they receive?
Very important question for sure. And I think, as you pointed out, we have touched upon this before, but I think there is definitely much more to be said and done. More importantly, I think the location has to do with multiple different, again, social constructs, right? The location and the distance from a cancer center with expertise is one thing. The time needed to get to the cancer center is related to that. And also the social support that the patient may have. If, for example, a particular treatment, for example, a clinical trial requires a weekly visit to the cancer center, is that a feasible thing for the patient who lives, miles and miles away in the rural areas of Oklahoma, as Dr. Nyame mentioned, or somewhere else? Can we design clinical trials that are more friendly to these scenarios, right? That require less frequent visits? Can we provide, if possible, funding for housing closer to the cancer center? And there are examples of cancer centers doing that. They provide, a temporary housing, for the patient to be able to be close to the cancer center, so they don't need to worry about going back and forth, across the state lines sometimes. The other thing, of course, is insurance coverage. And again, this can have some relation to location. And it's something we have to think about. How can we help our patients who have significant copays because of the particular insurance at that location being supported, by foundation or other funds that the cancer center or the state or, again, other foundations may have. The other issue is about access to diagnostics and treatments. There has been some, interesting discussion about particular prostate cancer, about access to what we call next generation sequencing, which is a diagnostic test aiming to profile or fingerprint the cancer DNA to look for particular mutations that the cancer may have that may lead to particular treatment options. If, for example, a mutation A is present, can we use a drug X that might be relevant in that context of that mutation? And recent data that was presented at the ASCO 2021 showed that if you look at those mutations, they are not very different, between, for example, white and Black patients. There are similar types and frequencies of mutations. What is different is access to the test, and of course, access to the therapy related to the test. So I think we have to do a better job bringing ourselves to the community, extending, our opportunities to the patient to get connected to the healthcare system, and they'll build bridges to bring the patient closer to the cancer center, offering those tests, work, with patient education to help a patient understand the significant value of the follow-up, but also provide them with, in a way that is equitable, access to diagnostics and treatments.
Thank you. Thank you so much, Dr. Grivas. And you've touched on something that I'm going to ask Dr. Nyame to elaborate on, which is these fancy tests and these new technologies and things. And what we know is that a lot of times the patient themselves, if they are not aware of these particular tests, then because of all the disparities that we've talked about, they may not even be offered to them. And so, question for you, Dr. Nyame, how can we empower patients so that they don't feel limited in their care? And how do we make them aware of these treatment options and diagnostic options that Dr. Grivas just spoke of?
That's very challenging because Dr. Grivas and I see this in our clinical practice, right? We have patients who are very savvy that'll come in and say, I've heard that there's a PSMA in San Francisco. Do you have it in Seattle? If you don't have it in Seattle, I'm going to go to San Francisco. And for every patient I have like that who might be, hey, have you read this latest article? I can have someone who has no idea what's going on with their diagnosis. And so how we create opportunities to bring those patients that know very little up to somewhere close, maybe not quite to the demanding the PSMA or fancy scan level, but sophisticated enough to feel empowered in their health decision-making is something where I think we need to do research, because we know that certain tools, navigation, advocacy groups can help in that arena, but I think that we need to understand what the tools are that patients want. What's interesting is when you query patients, which we've done in a study, and you say, what are the most pressing issues for you in your prostate cancer diagnosis, whether it's in the localized setting or in the advanced or metastatic setting, the one thing that is resonated over and over again, irrespective of race, is I need help making decisions. I need tools that will make me more efficient in how I make my decisions. And so I think without punting the answer too much, we need to do better. And I think part of that starts with listening. I do think that providers can be trained to provide that information in more efficient manners. We do not, we as clinicians are built into a system where the number of patients we see really correlates with how we get paid, okay? And there's not a doctor that doesn't go to work excited to educate and build relationships with patients. That's not the case, but there is a time crunch. And I feel like in situations where there's a bigger gap in knowledge and understanding, we often don't have enough time and built into our day to have the discussion. So for me, for a lot of my patients who I feel like have a lower understanding of what's going on with regards to their prostate cancer diagnosis, it's really important for me to build into our visit the understanding that whatever we don't cover can be addressed at a later time, and that we don't have to make a decision at that particular visit. So when I think about this, it's sort of like your favorite barbershop or your favorite, grocery store, your favorite sandwich place. The relationships matter. And I think when we talk about empowering patients to be advocates for themselves in their clinical visits, I think there needs to be an understanding from patients that if it doesn't feel right, that they have options. And to take their time in the decision. Prostate cancer, unlike other diseases Dr. Grivas and I treat, doesn't have to have the dial turned to 10 or 11 right away, and we need to make a decision, because time is extremely sensitive. Even in our most aggressive localized settings, which is what I treat, we have the opportunity to take weeks, if not months, to come to a decision.
Thank you. Thank you so much. I appreciate that. And certainly as a physician who's also a health advocate, I strongly agree with what you said about if the relationship is not working, that there are options. And I know that that may not always be the case, depending on where patients live, but I regularly encourage my clients to, sometimes you have to look somewhere else. Sometimes you have to get a second opinion, or maybe even fire your doctor if the relationship is not mutually beneficial. So I appreciate you sharing that. Dr. Grivas, do you have anything to add in terms of how patients can take a proactive approach to their healthcare and how they can build this confidence that we've been talking about and express their concerns to their medical team?
I think Dr. Nyame covered it so well. I think it's critically important, for all of us to recognize that finding out the why is probably the key to answer those questions. Why there is this distrust, why someone is not paying attention to his or her own health, because they have to try to make, ends meet and keep family fed, during the daytime, and they don't have time to think about their own health, as Dr. Nyame mentioned before. At the same time, empowering the patient that they're the center of this relationship, right? Why Dr. Nyame and me go to the clinic in the morning is because of patients. So our training, is a patient-centered, and our practice is patient-centered, and our research is patient-centered. So the patient should feel that, right, from the doorstep, that this is a service to them, and we're doing what we're doing to help their life being longer survival, as we call it, or better quality of life. And listening to the patient's needs is important. Because of the time crunch that Dr. Nyame mentioned before, where I think many of us, probably all of us, are within situations where we don't have enough time to listen adequately what the patient has to say. That's why I think it's important to have opportunities for separate visits and utilize better other mechanisms, adjunctive mechanisms. Patient navigation, I think it's a critical part of our care. Social workers, case managers, right? Financial counselors, nutritionists, genetic counselors, looking at genetics, right? And predisposition to cancer, which is much more common than we think across races, and sometimes maybe higher in some certain populations. Having these services available to patients can help a lot, because they will give them knowledge, and knowledge is power by itself. So giving them the sense that we're here for them, why they're here, it's because we want to help them, and giving them all the resources they need to get knowledge, information. When they feel they have more knowledge and they feel that they have control, they can communicate back and give feedback of how we can do better, and also what are the priorities of their needs, so we can address those. What matters to the patient, and this can apply to patient care and also research. What questions we're asking in research should be defined by patient priorities. So all of those factors should be a dialogue with the patient. I think advocacy groups, can be a great liaison to help us disseminate these concepts and help, again, empowering the patients. I strongly believe that, explaining the why and giving knowledge, the data points in a simple and lay manner can help patients being more in control.
Absolutely. Thank you, both of you. I love the patient-centered focus. I mean, that is something that, admittedly, we've gotten away from that to some degree in medicine because of the time crunches that both of you have mentioned. And I love that you said, Dr. Grivas, that knowledge is power. So as we close, I'd love for each of you to share maybe a couple of key questions that patients or care partners facing prostate cancer should ask of their treatment team to ensure that they're receiving appropriate care. So we'll start with you, Dr. Nyame. Any key question that patients should be asking their care team when they seek treatment or diagnosis for prostate cancer?
Absolutely. I think that there's a long list, actually. I'll tell you, my new prostate cancer diagnoses visits are usually my longest because there's a lot to consider. I do think, depending on what you're having done and what you're being considered for. So let's say in the localized setting, prostate cancer is confined to the prostate, and you're thinking about treatment like a surgery or radiation therapy. You really want to know what that center and what that provider's experience is. And because we have a lot of supporting evidence that the more people do in this, no one's going to be surprised with what I'm about to say, but the more that someone does, the better they're going to be at it. Okay. And so making sure your team has a good experience with what you're seeking to have done is important. And I think it's well within your rights as a patient to understand that. So I think advocate for that. Secondly, I think basic questions just to understand the relationship. I think I like it when patients want to know a little bit about me because they're going to be in my hands. And so, again, the importance of that relationship building in your visit is crucial. Lastly, I think when you come to the visit, have a list of questions based off of what you've researched and write them down. I find my most sophisticated patients are crossing off questions as I'm talking because they came prepared. And so that preparation, the act of doing a little bit of reading, there are a lot of resources. The Prostate Cancer Foundation, for instance, has a very nice patient guide that's written by patients in language that's really digestible and edited by experts. And so going through that and coming with your list of questions, I think, is a really important thing for your visit. Those are just a few things I can think of that can lead to a meaningful clinic visit and exchange.
Excellent. I'm a huge fan of questions and being prepared for visits. What about you, Dr. Grivas? Are there one or two key questions that you feel patients or their care partners should ask?
Great answers by Dr. Nyame. I totally agree. I think starting with the basics, what this diagnosis means for me, what is the current extent of the cancer, we call this stage, and what is the outlook, what is the overall prognosis, or at least estimate of the outcome. That's a reasonable question to ask. And again, some patients may know more details, some others may not, and it's important for us also to ask the patient what they want to know, how much they want to know, which I think most of them, they want to know the entirety of the information because it may help them make decisions. The other, I think, is important point is that what are the treatment options and what is the intent of the treatment? What are we trying to achieve by giving treatment? Are we trying to cure, eradicate, or eliminate the cancer? Are we trying to prolong life? Are we trying to improve quality of life? Can we just control the cancer? So what are the goals of the treatments and what are the metrics of success? So what will be a successful outcome of that treatment? How do we measure that? And I think it's also important, two more points I would add, if I may. I think, again, going back to the importance of genetic counseling, even more in prostate cancer, I think we recognize the importance in the aspect of patient treatment, because some treatment options may depend on finding of genetic mutations, but also the importance on the family, how much we can prevent cancers in the broader family, close and extended family. If we find a mutation, can we check this mutation for other family members and do screening to prevent cancer? Prevention is ideal if we can do that. And I think that's a good discussion so the patient can come to the visit, if possible, by doing some homework about the family history of cancer, right? Sometimes it's hard for all of us to know what happened in that cousin, right? But if we do have the time to be informed of the importance of the question, this can help and expedite, resources like referral to genetic counseling. And the last point is research. I want to, again, to make the point, we should all do a better job to offer innovative clinical trials to patients across races, and it should be a very important point, again, equity and equitable healthcare. And the patients should ask, are clinical trials an option for me? And do I have a clinical trial option? I think it's a great question, and hopefully this can help the patient get to an innovative treatment, but also help the field, the researchers get important answers. And the important answers can be for all the community and the specific populations. If you do trials, clinical trials with only white patients, do we have the answer for the Black patients? And we have the answers for both, and other races and ethnicities as well.
And I do want to take this opportunity to add one more thing, because Dr. Grivas talked about what does your treatment mean for you. And in this discussion about prostate cancer, we cannot talk about what questions you bring without mentioning the impact on quality of life of our treatments. And I think that sometimes this is the elephant in the room that leads to the decision to not pursue treatment. And so I want to take this opportunity as the urologist to say, this is the time to talk about what treatment is going to do for sexual function. This is the time to talk about what treatment means for your urinary symptoms and quality of life. A good and healthy discussion around these things need to happen during your visit, because I think sometimes what patients expect to have happen with treatment and reality don't match. And you have an expert in front of you that can really give you some input as to what to expect. And in a similar vein, when you meet with survivors, these are some of the things that I know patients tell me they're worried about. And these are people who are living it that can give you really valuable information on that piece of quality of life. And I hope that those conversations can help us close that treatment disparity that we see between Black men and white men with prostate cancer.
Such wonderful points. This has been an amazing conversation. Thank you so much, Dr. Nyame. Thank you, Dr. Grivas, for just illuminating so many important issues. You know, just to briefly summarize, we've talked about the disparities that exist in prostate cancer diagnosis and treatment based on geographic location, based on, you know, finances, insurance status, access, and yes, even race and ethnicity. And you all have done a wonderful job providing solutions. We've talked about the importance of advocating for yourself and your loved ones, the importance of being educated and doing some research, coming to those visits with your questions, making sure that you form a relationship with your treating physicians, and you know, sometimes perhaps seeking someone else if that's not possible. So just so many gems. And I just want to thank both of you for spending this time with us today. And I want to thank you all for tuning in to this Patient Empowerment Network program. I'm Dr. Nicole Rochester, and thank you for joining us.
Thank you.
Thank you.